And now I have the pleasure of kicking off our first plenary lecture. Both of these people need no introduction, but I'm going to try anyways. Dr. Becca Brendel is known to many of you in this room, but for those who don't know her yet, she practices at the Massachusetts General Hospital, where she's the Director of Law and Ethics at the Center for Law, Brain, and Behavior. She's also the Director of the Master of Bioethics program and Associate Director of the Center for Bioethics and an Associate Professor of Psychiatry at Harvard Medical School. Dr. Brendel's contributions to the ACLP have been deep and wide and include 10 years of service on our board, including as president in 2019. She's also been deeply involved with the American Psychiatric Association and today is speaking with us in her current role as the president of the APA. Dr. Saul Levin is also well known to many of you, as he's been the CEO and the medical director of the APA since 2013. He's originally from South Africa, but has practiced on both coasts of the US. He's a clinical professor at the George Washington University and a fellow of the Royal College of Physicians, Edinburgh. Dr. Levin has had numerous roles focusing on health policy and administration, including as the director of the DC Department of Health and as a special expert appointee with SAMHSA. And he has a long record of advocacy for underserved and underrepresented populations. We're going to be doing Q&A through the app. So please pull up this session in the meeting app. You can click on the Q&A button at the bottom and enter your questions there. If you see a question that's like yours, go ahead and upvote it, and we'll be reading off questions at the end of Dr. Levin and Dr. Brendel's presentation. It's truly an honor to have both of these educators and leaders here today to speak to us about CL's role within the profession of psychiatry and the broader house of medicine. Please join me in welcoming Drs. Brendel and Levin.
Okay. Good morning, everyone. Okay, I know we can do better than that, so let's start that again. Good morning, everyone. Great. It is such an honor and such a thrill to be back in person with all of you. And in all the years of my own career, and I'll talk about this morning, ACLP has really been my professional home. And when Sandy says, welcome to the family, this has been my professional and now my personal family too, in the many colleagues and friends over the years. So I'm going to get us started talking a little bit about how I see C-L Psychiatry as so critical to the role of the future of psychiatry more broadly, and then pass it off to my good friend and colleague, Saul Levin, who's going to talk about the collaborations and the very substantial ones that ACLP and APA are building to bring us to that future. Okay, I have no disclosures. So when I was first before you at a Thursday morning plenary back in 2019, we had no idea what was coming. And we were already facing a critical shortage of mental health resources in this country. We knew that we had huge gaps between in life expectancy for those with serious mental illness. And we also know that for those with medical illness, comorbid psychiatric illness also led to poorer outcomes. Now, this is on the public stage more than ever after COVID. And so in the past year, never did we think that mental health and a mental health crisis would make the State of the Union address for an American president. It's on the national agenda. It's on the news. It is in Congress. And we are facing, and it's in the print media. And so this is just a highlight of some of the different places where we've been talking about the need for mental health. And I've been doing advocacy on all of your behalf and on behalf of the APA in the past 6 months in my role as APA president. So I want to talk to you for the next 20 minutes or so about the unique features of C-L psychiatrists that I believe make us the leaders of the future of psychiatry. I think there are three reasons or three unique skill sets and attributes that C-L psychiatrists bring: understanding complexity, innovating for the future, and working and leading in teams and systems as three three of these reasons. And I'm going to highlight the journey in being before you this morning. I've been thinking a lot about my own journey and how ACLP has played such a pivotal role in that. And the practice of C-L Psychiatry has been so central. And I'm going to use a little bit of a narrative about this journey to highlight some of these points. Okay, so this picture is actually from 2007. I tried to find some earlier ones, but I started my first job in C-L Psychiatry on January 1st, 2006, after I finished my fellowship. At that point in the hospital, we knew that there were many psychosocially complex patients who were vexing the medical teams, right? So if I ask each of you to raise your hand if you've ever been consulted because a medical or surgical team didn't know what to do with a patient who was stuck on their service, right? Everybody would have their hands up in the air, right? Okay, good. Nice. Thank you for waving in the back. I've been feeling the love. Okay. So in 2006, we knew that capacity and financial pressures were leading the hospital to look for new approaches to these patients who got stuck. And we knew, and I'll show you some numbers, that a small number of patients accounted for a disproportionate number of hospital days. Some of these patients were medically ill, but some had long length of stay due to psychosocial complexity. This was the team. It was called Team 5 at the time. It's now the All Bright Orange team at Mass General. It was a dedicated medical team, multidisciplinary team to address these, to try to help both the system and to take care of these very complex patients. So as an embedded psychiatrist on a medical team, I provided clinical consultation. I did all the bread and butter things that all of us do every day. We were dealing with common consultation questions on behavioral dysregulation, thinking about how to manage existing psychiatric illness, substance abuse, and then also a really substantial amount of work around breakdown of the system, right? Patients who either were refusing care, couldn't accept care, were lost to follow-up, or we couldn't find a safe discharge plan for them and fulfill our ethical and legal responsibilities. So at this point in time, back in 2006, the average length of stay in our inpatient medical services was about 6 days. And we considered a long length of stay patient an outlier, someone who was in the hospital for more than 20 days. These long length of stay patients accounted for 4% of medicine discharges, yet 27% of patient discharge days, inpatient days per year. And so we knew that this was an area, if we could start to crack this nut, we'd be able to innovate and both provide better outcomes for our patients who are stuck in the hospital and for the system in being able to admit more patients. So the question really was how to identify this 4% of patients. And one of the areas was really at the intersection of law and psychiatry and medicine, where I spent the early part of my career related to guardianship cases. So we knew that if the average length of stay was 6 days, back in 2006, we had an average 35 days to be able to get a guardian for patients who are not able to make their own medical decisions in order to be discharged. And so from the guardianships, we had more than 1,100 potentially avoidable days back in 2008, which corresponded on an average length of stay to about more than 180 additional admissions at the hospital, additional patients the hospital could admit if we dealt with this problem. That would be an extra bed on the medical service every other day. Okay. So with this area of focus, we began collaborations externally, but we also developed a specialized inpatient team to look at all the guardianships within the hospital. The other thing that happened and really affected us is just as we thought we were getting better, the Massachusetts legislature changed the guardianship law in 2009, making it substantially more onerous. And you can see in the blue, the uptick of guardianship cases beginning on July 1st, 2009, up to almost 180. And you can also see that with this specialized dedicated team, we were able to bring down the median time to discharge from about 25 days down to about 16 days. All right, so that was back in 2008. And I want to show you that over the ensuing decade, this kind of collaboration between C-L Psychiatry, social work, case management, and medicine really led to significant results. So over a decade, we had a sustained reduction in internal processing time by about 5.5 days, a decrease in the average length of stay by almost 9 days, and also about 37% reduction overall in potentially avoidable hospital days. And we were also able to do better for our patients. So we were able to find solutions that avoided the restrictive measure of a guardianship in almost 30% of our cases. The most important piece that stands out in all of this, though, is that as with C-L Psychiatry, we had 0 potentially avoidable days on critical services, both for care and from the hospital and system perspective for revenue. Okay, so there's more to the story here, right? We're still talking about complexity and what C-L psychiatrists can do, but there's more to the story. So here what we have is, while the length of stay was longer for guardianship patients, if you can look in the second to last column on the bottom right, the expected length of stay for guardianship patients was also longer. And we wanted to know why that was. But the short answer to that story is something that we're all talking about now, almost 15 years later, as central to the work we do as the social determinants of health and mental health. So we knew that these non-medical factors were key drivers and determiners of outcomes. All right, so that brought us really from thinking about individual to population health level solutions. We knew that we had a small number of patients within the hospital on the outpatient side who were also accounting for many of our inpatient, many of our hospital resources. And in October of 2004, Medicare released a solicitation for intensive care management programs for high-cost beneficiaries to try to bring at least 5% of savings over 3 years, or we would have to return the administrative fees. And at that point, there was a huge concern about the rising impact of healthcare costs on our economy, with the GDP for healthcare at about 18%. We're now at about 20%. So we've stemmed the growth rate, but we still, 20% was seen as a critical place that the system would start to break down. We could talk about that more in terms of where we are now. The important part of the program that we launched for 2,500 patients is really in this pie chart. Okay, so with a psychiatry-led outpatient mental health team as part of the 2,500 highest risk Medicare patients in our hospital, only 10%, that's the small gray piece of the pie, had no past or present psychiatric diagnosis. Okay, so we learned that mental illness, psychiatric illness, was a driver of medical complexity, both on the inpatient side and now on the outpatient side. And the results of this project were really stunning. Mass General was the only demonstration project at the time that had a mental health component. You see with the arrows, we're second on that list. We had the benchmark was a 5% savings. We had over 10% savings within a 95% confidence interval. So it was the only one of the demonstration projects that integrated mental health and was shown to have savings. Okay, so what did we learn? We know that mental health treatment and needs are time and resource consuming. And that high-cost patients account for about 20% of our patient population in the outpatient setting for Medicare, but we're about 80% of our total medical effort. Okay, psychiatry really was a key part of shifting from this fee-for-service and individual patient model to be thinking then about population-level management. And this huge impact for patients with chronic illness is really important, and also important at the end of life. So I won't get into some of the end of life work we do, but that's another place that CL psychiatrists are making huge strides and huge differences in how we can deal with manage complexity and think about innovation. All right, let me just show you a little bit more data, which to me still remains stunning after all this time. So this was our original sample from 2006 to 2009. With the refresh, we had a total of 3,667 patients enrolled in our Medicare demonstration project. And you will see that of those patients, over 1,900, that's the first line on the left, met past or current criteria for an affective disorder. Nearly half, 1,600, presented with past or current substance abuse. and about the same number had some significant neuropsychiatric finding. So again, a different way of showing the evidence that we need to lead within medical settings because of the drivers of complexity. I should also say, and it's not in this data, that when we went back and looked at the data in 2012 from our outpatient program, patients were actually living longer and having better outcomes. So it showed both a cost savings and improved outcomes. So you might say that a Medicare population is not indicative of how we might solve problems and find solutions more broadly. And so we decided after the success with the Medicare project to expand to include commercially insured patients. This is data from 2012 that was started in 2009 after the original project. And from 2009 to 2012, these are the most commonly diagnosed clinical conditions in our highest utilizing commercially insured patients at Mass General. And what do you see? The most prevalent diagnosis at 55% is a mental health diagnosis, okay? If you look at the second line, the one that pales in comparison to the 55%, diabetes was only in 36% and heart disease in 25%. So if we don't need to lead in taking care of patients who need our care the most as psychiatrists, right? This should convince anyone who's not already converted. Okay. So this knowledge, we have this clinical knowledge, we know from our work in the hospitals, we know from our research in a number of different domains, really leads us to be able to lead for innovation in the future. So that's the second thing. The first thing that makes CL psychiatrists so critical to the future of psychiatry is our ability to take complexity like this, break it down, and then do something about it. The second thing is how we innovate. So the intensive care management models, integrated care, embedded teams, all of these clinical innovations are things that we're going to need to do to go forward. We know about collaborative care. Saul will talk a little bit more about APA's efforts on this, integrated care, reverse integration, specialty clinics, and continuums of care. These are all things that all of us have led on as CL psychiatrists. The second place which we're going to definitely need to go to is thinking about population health, which ties into some of these innovative models, but also puts direct care in context. It allows us to toggle between individual health and population health, think about social determinants of health and mental health, and lead to the models that are now coming forward and showing huge effect in terms of proactive consultation that can lead us to important and meaningful policy interventions. Okay. So the question that I pose to all of us together is, where do we go from here? Okay, I want each of you to hold on to this because we are in a unique position. As CL psychiatrists, we are in a unique position because we glimpse into and cross between so many different domains. We have this broad skill set of expertise and relationships. We know about our relationships like other physicians directly with patients. We know about the importance of relationships and fostering them and managing with our colleagues, right? And our colleagues, not just in psychiatry, but certainly in psychiatry, but within the House of Medicine, which is why the collaboration between ACLP and having representation at the AMA is so critically important. But we also know, and this goes back to the data about the complexity that's not medical or pure psychiatric complexity, that we know how to lead and interact with systems and systems of care. This is both conducive to solving problems, is also really important to examining the problems and to setting new norms about how we ought to practice in the future and where psychiatry can go. And there are key opportunities for advocacy at all levels. So this is a plug for a book co-edited by Dr. Levin and also by Dr. Ilse Wickers. I don't know if Ilse's here, one of our, I had the pleasure of supervising as a chief resident on our CL service a very long time ago. But really looking at the ways we can advocate from the level of there's a chapter on CL psychiatry, and really advocating from the level of the patient within the hospital all the way to the level of going to state and federal government to set policies that support the best care of patients. Okay, so where do CL psychiatrists fit in and where do we go in the future? So as I've mentioned, we can lead from our values, right? Our commitment to patient care and to working with our colleagues, our practice experience, and our varied perspective in all the different ways we do our work to toggle between persons and systems, insider status within a medical team and outsider status, right, as a consultant, care and advocacy, as well as trial and error, trying new models of care in small ways and seeing if they work, and figuring out the ways in which we can lead to meaningful change. In the post-pandemic future of psychiatry, there are rumblings and echoes of all these strains of the work that we do every day that will carry us forward. Specifically, models of care, thinking about new solutions to address, screen for and address the political and social determinants of health, and to think critical questions about on how we can contribute both to how we live, and then in our increasing work in palliative care and end of life, also how we wish to come to our sunsets. So let me start wrapping this up by saying that there's this concept of a super forecaster, right? So there's questions about who can predict the future. It's really important to be able to predict the future in order to be able to prepare and lead towards it, all right? And so business expert Tetlock in 2011 had this book called Super Forecasters, and he wanted to look at who are the people who really could be visionary about where we go in the future. And they looked first to expertise, people who had such knowledge about their area of work that they knew every aspect of it. And it turned out that experts don't predict well. Right? If you have expertise in one particular area, you're like a hedgehog. You're just looking at the ground in front of you. You know everything about it, but you get stuck in the weeds. Okay, so experts actually don't do a great job. The opposite, right? Then they said, well, what about people who have a broad perspective about everything that goes on in the world, right? What about foxes who are always scanning the horizon, right? Sly as a fox, knowing everything that's going on ahead of everybody else. Well, it actually turns out that if you're looking at everything, you don't have enough expertise to be able to look at, figure out amongst those things, which are the important ones that we ought to focus on. And so people who are super forecasters actually tend to have a good balance between both expertise and the ability to scan the horizon broadly. And I want to suggest that the C-L Psychiatrist, right, is the perfect super forecaster. We have deep experience and expertise in the treatment of comorbid medical and mental illness, while we are experts in the way that we observe, query, and navigate systems. But we also have the perspective, perhaps as the foxes, of seeing each patient in the context of a much broader system that allows us the perspective to prepare for where we need to go. I believe that we've already done that in being leaders in innovative models of care. With that in mind, this year as president of APA, I have convened a presidential work group chaired by Bob Trustman, who is the chair of the Council on Healthcare Systems and Financing of the APA, which has a huge influence from C-L Psychiatry. I'll do just a couple of shout outs of some of the key people here, but really to look at where does APA need to be in 10 years to be leading, and to make sure that every American has access to high quality, affordable, and accessible evidence-based mental health care. If we're going to be there over the next decade, what do we need to be doing now to prepare? And the role of C-L Psychiatry in this is invaluable. So as part of this presidential work group, as chair of the Council on Quality Care, Carol Alter, a past ACLP president, is sitting on that council. We have deep support from the Policy Programs and Partnerships division of APA under Kristen Kroger. We're actually building on one of my predecessors' work preparing for the future, Paul Summergrad, a jointly trained internist psychiatrist and longtime member of this academy. And then also collaborating with the Council of C-L Psychiatry. I'm so grateful for the leadership of our immediate past ACLP president, Maria Tiemsin-Casab. So our board has been working on this. We've been learning in a number of domains around the history, context, and ethics of how we provide mental health care, getting input from the future. So thrilling to see so many residents, fellows, medical students here this morning with us, and ongoing collaboration. Okay. I want to take a minute in ending my time with you this morning to thank all of you for letting me be part of this room and this room where it happened. I really didn't have any intention of being a CL psychiatrist when I started out. I was already a lawyer when I started my residency, and it seemed pretty natural that I'd go into forensic psychiatry. And I want to thank the Academy because these are 2 pages from the Academy website, but it all really started when I became a web fellow of the Academy and came to my first meeting and realized that being at the interface of medicine and psychiatry, bringing law and ethics and the other things that I was doing into that was really the place that we could lead and make the greatest impact. All the way to the incredible support, collegiality, and help that everyone in this room provided in the journey to becoming APA president. So I want to thank everyone, express my deep gratitude and appreciation for being here with you today and for the very many years, 19 of them, of membership, collegiality, and friendship at ACLP. Thank you so much, and I'll pass it to Saul.
Well, good morning. I want to thank you. And apart from those Klieg lights that are signing into blinding my left eye, which as old age approaches, I have a slight bit of sort of visual disturbance down the eyes, I like to call it. I really want to thank you for the invitation here today. And I want to thank Phil Baylor and the board and all the past presidents of that I know in my past 10 years here at ACLP, who've come to APA, sat as the chairs on our committee on the council on listen to ACLP, and also I want to thank all of you who are members of the APA. Because together we're stronger. This is your home because this is where you practice every day of your lives. But APA is the ancillary home that you have that can then take all your knowledge, take your expertise, and really then begin to expand it out throughout the whole of the healthcare delivery system and into the Congress, which we see as so important. I also need to thank James Brack, who's my equivalent here as your CEO, for all the hard work that he does that many of us don't quite realize what he does day to day in the job. So I really want to thank him, and please let's give him a round of applause. If we can go to the next slide. Thank you. Next slide. Am I advancing it or? Yep, I think I am. So here are my disclosures. I'm fully employed by the APA, the American Psychiatric Association. I also sit as the chair of the APA Foundation Board of Directors. And I also have a sister that's actually not up here, I need to put out, who sits on actually the board of Sutter Hospital Systems in Central California, where we occasionally talk about mental health and psychiatry, and we have to be very careful that I don't hear any of their dark secrets, and I don't want to let them know ours, as we look to saying, what are the hospital systems doing in terms of mental health? Let me go to the next slide. There we are. So I think you've all seen this over the years of what is APA. I'm not going to go through this. It's very complicated, but in some ways it does set out exactly what each and every one of you do every day of your lives. You advance the practice of psychiatry. You support research in terms of Consult-Liaison. Diversity is becoming a bigger and bigger issue. And as I look across the audience here, I am beginning to see really a diverse group of Consult-Liaison psychiatrists, which is really important. This country is changing. Our membership at the APA now is over 52% women, if I count the medical students, residents, early careers, and the early psychiatrists or the general psychiatrists in this country. There is a shift for us that more and more women are now going into psychiatry, and in some ways will ultimately be the majority. So to the women, I say thank you for allowing the men for 160 plus years to lead this organization. But it's now time for the women to also begin to step up now and take that baton and move us into the future, with men obviously alongside for them as both fellow psychiatrists, but also as mentors in psychiatry. And I think education, is one of the biggest issues we are here for. And I think it's that what gives us our credibility, and your particular credibility, when you go into the house of medicine every day, when you walk onto the floors of the hospitals and your healthcare delivery systems. So here's what I look at when I think of the APA and the allyship with ACLP. ACLP have had a long, fruitful relationship. You were, if I remember correctly, you were started in 1958 as an association, but I have a feeling that you were doing consult liaison, or the psychiatrists of the time were doing consult liaison with their colleagues at that time, with the knowledge that they had at that time. And boy, how much has changed in those 58 years that you've seen as you've worked with your colleagues, and how much respect you have brought to psychiatry and to consult liaison because of your partnerships with everyone there. So working together is a really important factor that we need to now ensure as we move into the 21st century or mid-21st century, that we begin to be seen as equal partners, not just where we sit outside of the system, of the general healthcare system. And you've been doing this every day of your careers. The collaborative care model, we've heard a lot about it. It truly is the way we can sort of exponentially get our services out there. As you know, it is the only validated model that CMS has approved, has billing codes for it, where essentially the primary care doctor who sees the bulk of our patients with some mental health issues or substance use issues in the early stages. That's when you as consult liaison psychiatrists get called in very quickly, to come and do when the diagnosis seems to be getting a little harder or the patient isn't quite responding to the treatments and you bring in the experts, which are you. But clearly that model now, where we have the primary care docs seeing the patients, they obviously have allied health professionals, psychologists, social workers, nurse practitioners, particularly in the behavioral health field, who will see those patients if it does have a mental health substance abuse component to it. But then there are psychiatrists in this program, getting paid in this program, to really look to make sure that if you're putting someone on medications, it is the correct medication. And you've done that every year of your lives and every year of your careers. But now it's time for all psychiatrists to begin to realize and learn from you, is they have a role to play in the 340 million people in this country. When we talk about, where are the physicians to take care of everyone? It's time now for all the psychiatrists, not only to begin to get the fellows, the early careers that are here, and the residents and med students that stood up. Was really very impressive to see that we are going to be stronger as we move forward into the new healthcare delivery system. So here are two reports that we actually work very collaboratively with your organization, ACLP. One was in 2016. One of the seminal reports was the dissemination of integrated care within adult primary care settings, which set the stage for collaborative care model. Obviously, Jürgen Unitzer and Wayne Caton, I met very early on my career in the late 80s when they were really developing this model, and came to, at that time, Adam Hart to say, would you fund some of the early research on it? The joint reports that have been valuable between all of us is one of the most important contributions you make, ACLP makes, to APA and all our members. and it's the reports which is practical, easily digestible, and even can go out into the general public. We have clearly begun to understand that we cannot hold that knowledge anymore to ourselves. We've got to educate the public. We've got to educate our patients and their families. And you have actually been doing that a lot longer than many of the other psychiatrists who may have been doing a solo practice, single patient, whereas you have been the force multiplier on this. Where's the future of psychiatry going to? I think we all know that coming out of the pandemic, there isn't anyone in this country, in this world, that didn't, for the 2 years of lockdown of COVID, and some of that lockdowns are still going on in some countries. If you look at China, they are still in lockdown around COVID, having not done it quick enough and ensured that they really had the vaccines available and also the treatments available that we have for their huge population of billions of people. But we all know that there wasn't a person in this room, in this country, that at one point in time in those 2 years felt depressed, felt anxious, had some PTSD, particularly when they lost loved ones, and knew their colleagues who also were in the front lines, who weren't at home doing telepsychiatry, also lost their lives on it. And you know what? The general population now sees all the work that you've been doing with them day in and day out, all your 58 years of this organization, and prior to that, that we are here to take care of them. And I think that's why we have a unique opportunity now to normalize that mental health, mental illness, and substance use is no different to any of the other illnesses that they have. And I'll talk a little bit about it later. The future of psychiatry, normalizing mental health, I think is going to be is how do we demonstrate, as I said in the pandemic, that we are inseparable to physical health? And I think all of us, and I think you particularly, has had to step up even more to help those with the primary care illnesses and diseases, because in some ways, sometimes they may not have been able to get to their primary care doctors, but you were there for them. Mental health is the largest part of our national discourse than we've ever had before. And I have to thank particularly the younger generations, the kids at school, the young adults who will talk about now their mental health issues that they suffer from as if it was just a normal illness like any other. It is the older generation that I sometimes feel that we still hold a bit of that stigma within us that we don't want to talk about when we are depressed, when we are anxious, and we all have some of those feelings that require medications for us. And I think the psychiatrists also have to make sure that our voices are heard loud and clear. And that is what a meeting like this does. Every one of you are going to go back to your hospital systems, go back to your practices, and above all, go back to your patients and their families to talk about that mental health and substance use now has come into its young adulthood, and that we do have the treatments for you and that we are there. Do we have enough? No, which is once again why collaborative care model really begins to bring in some of the other professionals who can help us as a force multiplier on it. Let me just get, I think, the future of psychiatry and advocacy. If we don't talk about it and make it a normal discussion in every conversation, no matter who you're interacting with, very often I'd hear when people would say, what do you do for a living? We'd start by saying we're physicians. And I've often said, no, we're physicians, psychiatrists. Yes, we all went through medical school. It what makes us different to the allied health professionals. But we need to start saying to them that psychiatrists are there to help and own it proudly. And sometimes I think we don't do it as much as what I'd love to see us doing it. So what I'm going to start asking us to do is I need you also to join us at APA, and you have done it. Your leadership, I can tell you, of ACLP has gone with us onto the Hill, gone into the administration together to actually talk to them about what is the need of psychiatry. why you need it and why it needs to be funded and increased in its funding. And if I go, I get seen as, oh, he's the head of APA. Yeah, that's his job to come and lobby for us and to give his case. But whenever I take any one of you in to that congressperson or senator's office, and you have come from their area, their district, particularly, it's amazing how the conversation changes. And it's amazing when we also take someone with lived mental health experience or substance use experience or their family members, how suddenly it becomes very personal. You know it because this is what you've dealt with through your whole career. It's how do we begin to now become a force multiplier? So when ACLP is on the Hill lobbying, I'm going to ask you, make sure that my team is there with you. They have contacts, you have contacts, but we all have to give that same message. We need more resources. We need more money for caring for our patients and their families in the mental health world. And particularly if you look at the hospital systems as they grow, are we growing enough community health psychiatrists? Are we growing consult liaison psychiatrists? When are they going to lift the cap and begin to start saying is that we can train as many psychiatrists who want to go into the field? Because otherwise there's always going to be a different level of care that the rich get for those that do not have as much financial opportunities to pay for services. The future of psychiatry, as I said, is collaboration. Clearly, we've done this. APA and ACLP have worked together to demonstrate the value of subspecialties. And I was going to start off with something. I thought, let me leave it more towards the end. And that is the change of your name. I know at one point you were the Psychosomatic Psychiatrists Association, but moving it to Consult Liaison really changed it. And you, in fact, were prescient, in saying, when we now talk about us being integrated into the whole healthcare delivery system, the fact that you are very clear that you are the consultants, you are the liaisons for care of those with mental illness and their families and substance abuse. So I applaud you now as we move into the new models of care, for at least showing that you have always been the door between primary care and mental health. You've kept that door open. I now want us to expand that door as much as we possibly can. I come to the last part of my slides, and this is priorities for the next 10 years. I think obviously we've got to make sure that we get allocated resources to prepare for the next COVID. COVID is not over. There will just be another variant coming. It may take a year, 2 years as this burns out, but sooner or later we're going to have another real big infectious disease. How do we ensure that there are enough psychiatrists, enough consult liaison psychiatrists, to begin to be at that front line as it begins to happen, to start taking care of those cases? Revolutionizing healthcare. You do it every day by going into those hospital systems, going into your clinics, and basically showing that we are part of the healthcare delivery system and we add great value. And that while the insurance companies may, as I just heard earlier today, one of your members came up to say that I'm now, as my system has grown, my practice, that now all of a sudden some of the insurance companies are now beginning to question every little thing I do. But what does that do? It takes away his ability or her ability to practice psychiatry, because now they have to sit with bureaucrats who constantly expect you to be filling out forms and providing more and more information on a patient, that when I go to the medical directors, when I meet with them once a quarter, and they keep saying, no, we've done away with prior authorizations, and I look at them and I say, then how is it, as one of the things I get most complaints about coming to my office is the barriers that you're putting up. And in some ways, you are that first force that goes in and in some ways shows that those barriers can be broken if you just bring us into the team. Recruiting the next generation of psychiatrists. You seem to be doing a pretty good job, as I watched all the younger generations stand up here, and in fact, getting them to come to your meetings. But I'm also going to say you need to also come to the larger house of psychiatry's meetings as well. And I say that because, one, you will meet some of your other colleagues in specialties and subspecialties of psychiatry that you may need for one of your patients. And this is where those mentorship and those relationships, when I see your fellowships that you have. I was a fellow, a leadership, what's now called the leadership fellow. I still have contacts with many of my colleagues that were in that fellowship. So to the fellows, remain connected to your colleagues. I can call up people across this country who I worked with during my fellowship or a current fellow with me, and we have a bond already of to say, help lead me, because there's someone in your state or your hospital system that is called to say they need some additional help. And promoting and supporting medical research. We are doing some amazing work in research and psychiatry. You're honored with the Wayne Caton Award. Amazing research. It's how do we get those messages out? And I'm going to offer once again, let APA as a force multiplier also gets out. Let's publish in Psych News. That is a huge following of reading Psych News. Of when you have someone as wonderfully accomplished as your research fellow you're honored today. Let's put her into Psych News. We are with you. We are part of your family, and I want us to be closer and closer together. We've got to lead societal discourse on mental health and substance use disorders. It is time for us to stop saying we're no longer on the outside of the healthcare system, we're on the inside. And I'm happy to say that I'll talk a bit about it now as to what APA is going to be doing and APA Foundation. It is time for us to normalize mental health and substance use like any other illness. And the APA Foundation has begun to put in $2 million to begin a national campaign. Television, radio, newspapers, social media, and it's just the beginning of what's going to be a 5-10-year project. And we're asking also our other providers and funders to put in money. The Huntsman Foundation out in Utah has just given $200 million for the next 5 to 7 years to begin to normalize mental health, and substance use as just part of the healthcare system of care that's needed. And I'm going to need you also to become involved in those. So when we do create those ads, it's not just someone who's a talking head. It's someone who's an actual practitioner, you as the physicians talking about a patient you had and how you were able to help them. Because that is what's going to make us begin to turn the clock. And it has turned a lot more to us just being part of the House of Medicine. So with that, I haven't looked at my clock down there. I have 6 more minutes, but I'm happy to donate it to our questions and answers on it. I want to thank you again for always making me feel part of your family when I come. I came a lot more before COVID, and I hope I'll be coming a lot more afterwards. So thank you all, and thanks for my dithering up here. But just know you're family, and I expect to see you in San Francisco when we finally get back together again. And many of your key leaders are actually speaking at that meeting. Thank you.
Thank you so much to both of you. I'm supposed to go over to this podium.
Oh, okay.
Thank you so much to both of you for sharing the collaboration of our organizations. I've got a couple of questions from our members. The first one really is asking about, and this blends, I think, several questions, but we all know that workforce issues are there. And that we need to collaborate with non-psychiatrists as well as with non-physicians and the importance of that. At the same time, there's a tension in that of finances and people not necessarily being hospital systems, insurers not necessarily willing to pay for our expertise. And so the question is, what's APA's plan to advocate around those issues and thoughts that you have about that?
Okay, that's a great question. Thank you, Laura. I can't see you with these really bright lights. There you are. Anyway, okay, I can give you a hug after this. Okay, so this is a great question. So, we know that we have the knowledge, expertise, and experience to be able to treat patients to the highest level. and that nobody else has the same expertise as psychiatrists and especially CL psychiatrists in medical settings, but on mental health teams. One of the things that APA is doing actively, both in state and at the federal level, is really working to fight for patient safety. So this includes independent practice of non-physicians, as well as in a recurring intrusion into patient safety of psychologist prescribing. In some states, the proposal is for psychologists who have less than 450 hours of online pass-fail training and a 150 question multiple choice test to prescribe medications for psychiatric patients. APA is doing this in many, many different ways, but we have to have the data to prove what we know. So we have some data about the outcomes, but all of you know about working in collaboration and working in systems, and we need you to help us collect the data through our registry that is rapidly getting off the ground, to bring your health systems into this registry so we can show that the outcomes of physician-led teams lead to better mental health and medical outcomes for all patients. A really critical question. That data that could come from participation in our registry is what will allow us to go to state legislatures, to state medical boards, and to Medicare and CMS and say, do not expand practice for non-psychiatrists, allow psychiatrists to lead teams in models of care that give patients safe care and the most effective care that's evidence-based.
And if I could just expand on it. So I had the wonderful opportunity of watching a debate that happened through the Cato Institute literally a week ago, I think it was, or just over a week ago. And there was three psychologists who had been picked to talk about why psychologist prescribing should be just like any other psychiatrist should have be able to prescribe any medication. And we had one psychiatrist sit on that panel. And I'm going to say it was not Sandra, it was not me, but it was someone else standing on here. And I'm not tooting her horn, but if ever you want to see someone who truly, I cannot tell you how I was blown away, answered every single one of their examples of why they are equal to psychiatrists, prescribing. It was Dr. Weintraub Brendel. And I've got to tell you, you obviously, when you chose her for your president, you obviously knew what she could do, but it is well worth going to listen to, because even the moderator, who was a surgeon, and I wanted to say, now, what does a surgeon have to do with scope of practice of psychiatry, and medications? Even he, by the end of the call, just knew that if he asked a question, that Becker would come out with the answers that kept all the other psychologists on their program quiet. So I urge you to go and look at it. Now, I'd prefer you to do it through the APA website, because if you do it on the Cato website, it increases their hits, which gives them greater, more publicity. And to be quite honest, I have nothing against the Cato Institute, but I'd rather you see it on our website so they don't get the benefit of all the hits and getting more people to go and look at their website overall.
All right, with our remaining 44 seconds, Becca, question from a resident. Should someone who's interested in practicing CL psychiatry do a fellowship? And if so, why?
Okay, I'm going to plug the closing debate about fast tracking and CL fellowship, but let me say this quickly, right? I could never have imagined as a resident the kinds of opportunities and training I would gain from a fellowship training that for me was in forensic psychiatry, but had a lot to do with general hospital forensic psychiatry. It gave me the mentorship, the supervision, the collegiality to be able to go forward and lead both in our advocacy and in our practice. So CL psychiatry, formal training, becoming part of the family. Let's end where Sandy started us out this morning.
Thank you to you both for joining us and for your advocacy for the profession. And with that, we'll have a bit of a coffee break and then start our first breakout sessions at 11. Thanks for your attendance.